Stroke is a leading cause of death and severe long-term disability. It occurs when part of the brain is deprived of oxygen, causing the brain to die. People at risk for stroke include those who have high blood pressure, high cholesterol, and diabetes. Recovery time after stroke varies from one person to the other, and it can take weeks, months, or even years. Some people recover fully, while others have long-term disabilities, which can impact their physical movement, speech, their daily activities, for example, eating, dressing, among others. Now, tonight we'll be talking about how to handle yourself after stroke. And our guest tonight is Duncan Chengo. He is an occupational therapist, and he'll be bringing us to speed on that. And of course, we encourage you to engage with us at Hope TV Kenya on Facebook and YouTube. And of course, our WhatsApp line is 0708 222 323. That is 0708 222 323. And our SMS line is 222 322. That is 22232. Good evening. My name is Grace Mutis, and welcome to Health Check. I trust that you had a beautiful week. Allow me to invite on set Duncan. Good evening, Duncan.
Good evening, Grace. How are you?
I'm fine. It's been a long time since you joined us on Health Check.
Yes, it's been a while. I'm surprised today we are just two of us. You could have told me we are just two of us. Yeah? I could have carried Kenya.
Of course, with the Lord. Welcome, Duncan.
Amen.
So let's begin by just understanding who is an occupational therapist.
An occupational therapist is a clinical professional. We say it's an art, a science at the same time. In this art and science, you look a human being as a performing being, and someone who has chores to deliver every single day. And this type of chores, they vary, and they vary based on whether they are instrumental or they are simple daily living activities. Daily living activities including what you do. I know before this show you had your first foundation, second, third. You know, though that ability to keep you look nice,
Yes.
making your hair,
Yes.
your oral hygiene,
Yes.
dressing up, buttoning up, zipping, all those, they are very simple elements of activities of daily living. Of course, on the other side, before you do those very basic foundation, after all that is done now, then the instrumental one comes. You know, Grace, the host, who hosts a TV show. Mm. So occupational therapy is that science and art when you can't do all those things for whatever reason, most probably because of sickness.
Yes.
It gets you back to doing those things again. Of course, whenever occupational therapy is being mentioned, there must be a disability which is next to be managed.
Yes.
Or which is just next to happen and you need to prevent it. Mm. So the whole essence of occupational therapy is helping people who have acquired disability or at the verge of acquiring disability to mitigate it and help them engage into those activities without limitation. And the whole agenda of occupational therapy is simple, is to promote independence, such that you don't have to keep on asking, please, could you help me zip here? You know, could you help me please do my foundation one? You know, it's empowering you despite your current status and the challenges that you're going through.
Yes.
The question is, can you really be independent? So my role here is simple, to bring you to that level where you can do all what you have to do,
yes,
and you are happy thereafter.
Okay. Yeah. And what are some, you've mentioned you help a person who has one form of disability or the other gain independence. So what are some of these disabilities, you know, that will cause one to seek help from an occupational therapist?
The disability world is a very complicated world. It's indeed a maze. And of course, it's planned based on how it presents itself. The leading one, the one you can't miss, is a physical disability. Like in the case of a stroke, if you find someone who is using a wheelchair, someone who is using a walking frame, someone who is using a walking aid, you know, a stick, you know, you are limping. So those are classified as physical disability. Away from that, you have what we call cognitive disabilities. These are disabilities that are anything to do with your abilities to think, things like thought, orientation to time, place, and person, perception, memory, concentration, just to mention but a few. On the other side, you do have what we call systemic disabilities, whereby, for example, your all vision has an issue and you can't see. You find, your ability to hear has been challenged. So there are some specific systems that have a challenge. Pediatrics clientele or pediatrics level of disability, they can be a little bit complicated on their own way. And we can have developmental disabilities where under what we call neurodiversity. These are children who, for whatever reason, they don't socialize in the regular way the other children socialize. And these are the likes of children who live with ADHD, children who are autistic, children who live within the spectrum, just to mention but a few. Then when all of that is said, we cannot leave mental health when you're talking about disability, of course, because it's one of those areas which is really becoming a little bit of troublesome in our current days of life, the days of our lives, where you no longer take care of yourself the way you do just because you wake up not feeling the way you should do. And these are issues of depression, issues of anxiety, just to mention but a few. So disability is very wide, but for today, we're going to talk about stroke because that's the reason why we are here.
Okay.
Yeah.
So let's dive into it. So what, as we talk about stroke aftercare, what is involved, in the rehabilitation of someone who's had stroke?
Rehabilitation after stroke can be also very wide. So there are quite a number of few things that you want to look based on the challenges that the patient is presenting with.
Yes.
And that's where we derive our objectives from, the challenges that they present themselves with. Of course, the leading ones is always mobility. Because when stroke hits you, you suffer difficulty in moving from one place to another, how you sit, how you stand, then how you walk. So on priority is always mobility. And our work is just to train. We literally train you how to walk again. It's like you're a small baby, you are literally born again. And then we're gonna walk with you stage by stage every single day. We teach you how to sit afresh, how to stand up afresh, and how to walk again. And other than that, there are quite a number of other challenges that come together with stroke. And these include things like swallowing. Yes. Where you realize your ability to, because stroke affects muscles. Because the brain is very critical in controlling movement, what we call motor patterns. So swallowing, it becomes part and parcel of, muscle action, how your muscles contract and relax in an effort to try and push the contents of the mouth down to the gut. Yes. So you're likely to find at this particular point, the swallowing ability is not there. And this is a very critical part of care. You make a mistake at this particular point, you end up losing the patient out of aspiration. So it becomes a very sensitive area. Yes. Away from speech, hand in hand is language and the speech bit of it. Stroke, and especially stroke that affects the right side of the body, it's always accompanied by challenges of language and speech, because where the right side is in the brain, of course, it's the left part of the brain, is where the speech, area stays. And when this happens, it's likely to be affected. Yes. And you may want to help someone to take you through the language and the speech orientation again. Then away from the ones I've mentioned, then you cannot run away from the performance of the hand. It comes a time when we separate, in rehabilitation, you separate the upper limb and the hand completely away from the other rehabilitation of the stroke. Because
what do you mean by upper limb?
The upper limb this is what we call the hand.
Yes, this
clinically,
one.
This one. Then we have the brachium, which is the forearm,
Yes.
and then antebrachium.
Yes.
So we have this, this, and this.
Yes.
There are three of them. They are components of the upper limb.
Okay.
Yeah, and then the leg is the lower limb.
Ah.
So you are likely to come at this level because the human hand is very critical in doing those chores that I defined when we were beginning the show,
Yes.
in performing those, the zipping,
Yes.
the buttoning.
Yes.
The
foundation, of course.
the level 1, 2, and 3.
Yes.
How you put on your specs, how you manage your hair.
Yes.
Those very basic things. So it comes at time, especially the fine motor bit of it. Now, it becomes a little bit tricky when it is the right hand which is affected.
Why?
Because the world's largest population is right hand dominant. Now, the dominant hand is the hand that does all those chores. Now, once you lose the functions of the dominant hand, then rehabilitation takes a whole different direction. It takes us to what we call constraint-induced movement therapy mode, where you have retrained the unaffected hand, which is the left hand, or the right hand for that matter, if you are left hand dominant,
Yes.
to take up all the functions of the dominant hand. This includes you being told again. I remember when we were in nursery school, with that writing that you do like this,
yes.
or like this, zingzang.
Yes.
My teacher used to call them zangmwange, like this.
Yes.
We begin you from there again, because you have to teach again the art of writing again, all
Yes.
afresh.
Yes.
So it becomes a little bit of a tricky place, yeah? So at this particular point again, in rehabilitation, areas of rehabilitation again, and the hand is involved, then we have to discuss about ADLs. Simple things like dressing. Now, if this hand is not there to help this one to button,
Yes.
then modification is a language that we must speak at this particular time. Will I be forcing you to put on a tie every single day, that you need to button those small buttons? So an occupational therapist comes at this particular point and then looks at you and must make a little work easier for you.
Yes.
And then we do environment modification. Environment includes dress, becomes part and parcel of your environment, your shoes,
Yes.
you slip in and you walk,
Yes.
your bra, you don't have to take your hand behind to tie it. You do like this, and then somehow it fits. So we must teach you all these, sorts of skills again.
Yes.
So in a nutshell, those are some few areas of stroke rehabilitation. They can be a little bit detailed,
Yes.
but technically this is it. And just before I forget, allow me to mention this because it's very critical.
Yes.
The mental health. Research has shown that out of 5 people who have suffered stroke, we lose 3 of them within their first year of rehabilitation because of mental health. Simply, to be specific, because of depression.
Talk about that. What happens such that this person gets into depression?
Grace, when you wake up one morning and your status has changed, you can no longer walk in the kitchen and cook for your children again. And then here I am with you, telling you your status has changed. The ability to perform and to carry the challenges that come together with the disability. And then assuming your status again.
Yes.
The Grace who hosts the show. And then you ask me whether you're gonna go back to work again and host the health check, and all those. You are a CEO of a certain company, of a certain bank, and you wonder, you can no longer remember. Your memory is completely gone. And here you are.
Yes.
Your speech is gone. You can't speak again. And you host this show. The your inability to try and contain all these things together and accepting them and then taking them over and, ile tunasema mapema ndio best.
Yes.
Yes. Dusting yourself and standing up and saying this is what it is, and I must move on. That's what becomes the biggest challenge for people with stroke.
Okay.
Yeah.
Even if they go through occupational therapy, still depression would
I'm
come
sure somewhere
in?
on the process of this show, we'll talk what
Yes.
recovery is exactly.
Okay.
It comes a time when recovery, we define recovery otherwise.
Oh.
Not just you becoming
Independent.
you again.
Okay.
Yeah.
Okay.
Yeah.
So I know you've mentioned the different disabilities, that come with a stroke. And a thought came to mind. So is it only adults who are affected by stroke, also children? And would the disability, handling the occupational therapy be different for children?
Apparently, not many people who know, but stroke happens in children. I worked for Nairobi Hospital for many years, and one of my favorite areas in Nairobi Hospital, for those who we work together, they know it used to be nursery. And I put on a policy where every single mother who is hypertensive or lives with diabetes and is expectant mother, there is a very high chance. We call them pregnancies at risk.
Yeah.
You stand a very high chance of delivering a baby who has a challenge similar to that of stroke if you suffer any of those conditions.
Yes.
So ideally, stroke is acquired from a brain damage. And there are quite a number of other things that can lead to a brain to be damaged, including simple things like taking, drugs and substance when expecting. Even malaria is a major cause of brain damage for children, especially when mothers are expecting. Now, this is what I have to say on this. It's to be very specific on children.
Yes.
There is no child who is meant to have a hand dominance, either left or right, before the age of 3 years.
What do you mean by that?
When a baby is born, and for whatever reason, for the sake of what we call early diagnosis and early intervention, and you realize your child seems to be right-handed or left-handed, that is not true. There must be a problem. Investigate, go to the details, ask the pediatrician, ask for an MRI, ask for a CT scan. Because when you see one hand which is lazy, then there must be a problem here.
Okay. So a lot of observation needs to be done by the mother. A lot of
observations need to be done.
Okay.
And then risk pregnancies.
Yes.
It's very important that you ask your pediatrician to screen you right.
Yes.
And I also want my colleagues, the pediatricians, if for whatever reason you suspect something may be wrong, it's very important not to wait and see. We are a team and we work together. Yes. So ask me to have a look and advise.
Okay.
And even the child clinics, the nurses who are there, let's share the details. The earlier you intervene it, the better. Yeah.
So let's get into a bit of practicality here. And the question I want to ask, so how do you as an occupational therapist help a person living with stroke gain independence?
Independence is the language of occupational therapists. I teach students as well. And I tell them, when you ever one time wake up and you rub the word independence from your practice, then you need to resign and walk away. Enabling this person, doesn't matter the status this person is. Teaching enable this person to cope. For example, a right-handed stroke, and this is the dominant hand. It is your responsibility to make sure this person will go back to job when this person can write. All right?
Yes.
So you must retrain, again, hand dominance transfer skills. That's one of the core areas where occupational therapists are very, very good at it.
Yes.
You teach the skills. I use my right hand as good as I use my left, because, after many years with patients, I ended up being ambidextrous. So I teach you how to write. So transferring skills is also very possible. It comes a time, like one time, your neighbors across, there was one time there was an accident and some secondary school girls lost limbs. And I remember at that time, the National Examination Council writing to me and asking me to advise how the exam is going to be done. And they had no limbs.
Both of them.
Both of them. So at that particular time where now you must use your occupational therapy skills must come loud and clear.
Yes.
But you can still write with your mouth. Are you aware? You can still write with your foot. It's just about modifying the environment, making sure, for example, if you're writing here, you can modify how to deliver the exam itself, such that it's no longer written.
Okay.
These days you can use technology.
Yes.
So there are quite a number of ways how occupational therapists can come handy, but that's just but one of them. The other way, which is very critical, is environment modification. Now, I've lived in Nairobi for quite some time.
Yes.
And Nairobi, we need help, especially some parts of this Nairobi. How would you build an 8-story house? You have no reservation for a lift. And then you go get admitted, you have a stroke, and discharge comes in, you're going home. How do you go to the 8th floor?
Yeah.
We build
Yes.
homes, and you build the upstairs floor, the master bedroom, you know?
Yes.
And the down one down here, you call it for visitors, yeah?
Yes.
And then you put the kadolo size, this size.
Yes.
Not envisaging one day like you never get old and go there, you know?
Yes.
So environment modification happens at this time. The number of houses nimebomoa this Nairobi, sometimes it hurts me,
Yes.
you know? Because you are the owner of the house, I have to bring you home,
Yes.
all right?
Yes.
So I must to create a space enough for that particular point, the wheelchair must go in. The bed, nursing bed may need to come in because it comes a time after stroke where you may not, once the aftermaths of the stroke are dealt with completely, there's no need of staying in the hospital because our infrastructure of rehabilitation in this country has a challenge. Can you imagine, as a nation, we only have one neuro-rehabilitation institution. It's called the Kenya Spinal Cord Injury. It's up here.
Yes.
The rest are what we call acute setups in the main hospitals. So the physician will discharge you to go home while still on on nursing processes.
Yeah.
Probably you have a tracheostomy, or probably you have a peg, you know, because once you get stroke and you can't feed orally because of the challenges of swallowing that I told you, you must find an alternative for feeding. So all these processes are there and they're still in situ. So we must find a way of how to take you home when you... So here comes.
Yes.
The bed won't go in the house.
The wheelchair.
So environment modification, you need toilet to be modified. You need something, it's called Maggie slings, something that you can grab. You need side rails where you can hold as you go to the toilet. You need rails to take you to the dining room, to go out where you burst for a sun. Or you need a ram, and you know how we build in this Nairobi, without considering.
Okay.
And this is the high time as Kenyans, whenever you're building a house, you think that where we see your mawe, one day it can happen.
It can happen.
And that particular point, you need infrastructure will help you live in your house happily.
Okay.
Yeah.
That's a good point for us to pause, reflect on what Duncan has said. And for you building a house, have you considered a ram or a lift? And is the door wide enough? Because one day it might come. We pray that God gives us good health, but who knows? You are on Health Check right here at Top TV. Look and Live. My name is Grace Mutisa. I'm hosting Duncan Chengo, an occupational therapist. Our focus for today is stroke aftercare. Do you have a question? Talk to us on 0708 222 323. That is 0708 222 323. That's our WhatsApp line, and you can also SMS us on 22232. When we come back, we'll be sampling some of your questions and comments right here at Top TV. Look and Live. And I hope you're sharing this link with someone who will benefit from this information. We'll be right back.
Every Wednesday at 7:30 p.m. Spotlight.
Do you feel that they are in a place where they can effect a Barack Obama moment?
When you hear the word of God and you hear Jesus is speaking,
Real talk on real issues.
You know, the Bible says faith without works is dead.
The truth of the gospel that will survive the time is not a health and wealth gospel.
When there is time to harmonize and bring one composite amendment.
With idealistic, thought-provoking guests.
So people come to be serviced, to be encouraged, to be empowered.
When the storm is over, you desire the closeness you have with God.
Hosted by Reverend Edward Furi.
Only God can turn a mess into a message.
I have a boy on a wheelchair.
Yeah.
I'm still preaching on the pulpit.
Amen.
Niliona mguu ya nyuma inakuja tu kunikanyaga, imenilenga tu kwa tumbo. Nikaitana tu Jesus.
I got tired of working with the x-ray papers, and one day I just woke up and decided to burn them.
A test into a testimony.
The whole community didn't want to hear that anybody is born again. Excommunicated straight.
Bila Yesu hakuna njia.
Join Sharon Naitore Wangenye on Testify.
Katika hiyo harakati hiyo spirit kakemewa, mimi nimeona Yesu Kristo namna hii. Kwa msalaba. Opa. Hallelujah. Hallelujah.
Every Thursday at 8 p.m. for a moment to grow your faith some more.
Hope TV is where you look and live, with an excellent selection of the best Christian programming consisting of local and international content of inspirational stories, talk shows, Bible commentary, youth, health shows, children entertainment, contemporary gospel music, extended times of worship, live broadcast, news, movies, drama, Christian ministry programs, and so much more. Hope TV is another quality service from Christ is the Answer Ministries, with over 45% of authentic and credible local content every week. Hope TV is a sister station to Hope FM, Kenya's leading Christian radio station, with footprints across the country. Tune in to Hope TV, where you look and live.
We are glad you are still tuned in to Health Check right here at Hope TV. Look and Live. My name is Grace Mutisa. Today, our focus is on stroke aftercare. I'm hosting Duncan Chengo. He is an occupational therapist. Do you have any question or comment regarding our topic tonight? Talk to us on our WhatsApp line 0708 222 323. That is 0708 222 323. And also our SMS line is 222 322. The lines are right at the bottom of your screen. Let me just sample a few comments that have come through. Gilbert Moranga also says he's an occupational therapist, and just echoing what Duncan you said about environmental modification and tools adaptation to suit our clients. That is really needed. Thank you for that. And I can check on YouTube. Brian Waweru, thank you so much for tuning in. Bella Kiprono saying, that's my lecturer and my boss. Mwanafunzi is tuned in. Sami Nzogu, welcome. Thank you. Saying very informative. Medflix Hospital, tuned in tonight and saying insightful. They're using big jargons here. Biomechanics, super chef, and kinesiology, something like that. Thank you so much. One of our viewers watching us from Saudi Arabia saying very informative. Thank you so much. Mungash Kish is saying kudos to Daktari, and you're tuned in from Meru. Do you have any question? Keep them coming on our WhatsApp line and our SMS line. We'll be getting to them in a short while. So Dan, let's talk about some of the cognitive activities that we can engage any patient who suffered stroke to help them in the recovery process.
Cognitive activities. So after stroke, it's very easy to wake up to memory or mental faculties that seem to have completely been swept away. And on top of the cognitive abilities is the memory. So beginning with the memory becomes the easiest thing to do, because if you can help me begin connecting for example, I look at you and say, oh, this is Grace.
Yes.
Identifying the close family members. We have had scenario where someone will not differentiate between the wife, the daughter, or even the girlfriend. I've had such very interesting scenarios in ICU before.
Yeah.
Where you call one another the other, and then you are.
Oh. Yeah.
So at that particular point, you need to use pictures.
Yes.
Family portraits.
Yes.
And then you go slowly by slowly. And then in memory, we have something called nomia, from the word noun.
Mm-hmm.
Noun stands for people and names of places.
Yes.
And the names of things as well.
Yes.
So you begin with the close family members. Mm-hmm. Then you have a picture, right? And you ask, and who is this? And who is this?
Yes.
And who is this?
Yes.
All right? And then from there, now family takes over. Because some of these things, ideally, from a clinical circle, I may not deliver them perfectly as a family would.
Yes.
Why? Because in every picture, pictures have memory.
Yes.
By themselves.
True.
You know where we were, what were we doing, where had we gone there to do, you know, and then you follow up the story, because you can write a story using pictures. So that's one of the small things that we will probably teach the family, and then the family catches up from there slowly by slowly.
Okay.
The other thing is names of places, right? Where you've been before, you know, and then putting them into slowly by slowly. Things like simple greetings. Good
Yes.
morning. What time is it today? Because we have what we call orientation to time, person, and place.
Yes.
And then what time is it? It's lunchtime. You need to eat. And making sure you do that intentionally. It's
Yes.
lunchtime.
Mm-hmm.
It's dinner. It's time to sleep. It's time to wake up. Right? It's time for medication. And then you communicate with an intent.
Yes.
All right? Now, one of the most important thing about these early cognitive events, they are likely to determine your journey of recovery. If I have a problem of identifying who you are and what you're going to do to me, and knowing who is my wife here, who is my son here, the significant others at this particular point. Because these significant others, they are very critical in this process, in the journey of recovery. Then you're likely to have a very big challenge in the recovery journey. So memory here, by all means, in my history of practice,
yes,
this one I can't miss. It's my strong tool to handle.
Okay.
The moment I get to know I've brought everyone on board and you can identify who is who within the journey, then the rest of the things now I can begin fixing them.
Okay.
Cognitively, again, the next question when you begin getting your memory, then would you identify your simple tools of trade?
So if I was a TV presenter, would I know microphone?
Thank you.
On my screen.
If I show you, for example, your fellow presenters.
Yeah.
I show you Kerry. I know I've hosted a TV show with Kerry here before.
Yes.
And I ask you, and who is this? And what shows does Kerry host?
Yeah.
I take you through the newspaper, whether you can remember those very basic things, tools of trade. Of course, at this particular time, don't forget I'm also on a diagnosing journey.
Yes.
All right. There's something called aphasia.
What's that?
In stroke.
Yeah.
It's a disorder of speech and language where I may know everything or may hear everything, but I have a problem with expressing it. Or I would express things, but behind those things I'm expressing, there is no meaning. I talk, it's a careless talk that has no comprehension.
Yeah,
behind.
it's like there is no connection.
Yeah, there is no connection.
Okay.
So you can find some of these people have those difficulties. So it's through the process of all this cognitive journey that you are likely to make some of these decisions.
Okay.
Because as the journey progresses, you're likely to have team members other people, a team, because you cannot manage stroke alone.
Yes. Who are these team members?
These team members must be there.
Who are they, apart from family members?
Of course, family members. They are key. They take the stage. On the lead of the team, the physicians.
Yes.
Because stroke can be the leading cause of death. So the first thing is we need to save your life.
Yes.
Especially where there are cardiac issues like cardiac arrest, etc., etc.
Okay.
And then they take the role stage because we must arrest the situation. And then once we arrest the situation, then we need to stabilize you. And then when we stabilize you now, we ask ourselves, so where do we go from where we are? So we have our colleagues, the physiotherapists, they're big time in taking their mobility back. We have speech pathologists who take a key role again in managing the speech and the language bit of it. We have the mental health experts here. Very important colleagues, very, very important, who must take their role to make sure that we reduce the mortality rate for stroke patients, because research has already talked about it. And then nutrition becomes very key, because stroke is a lifestyle disease. Nutrition is part and parcel of our lifestyle.
Yes.
So if you don't take care of nutrition, you slide back again to stroke. Because where there is one stroke scenario, there is a very high probability it would strike again.
Yeah.
So nutrition here becomes very, very, very critical. Physicians can be of different backgrounds. The cardiologist, you could also have the neurologist or the neurosurgeons. A stroke that has got bleeding, what we call an hemorrhage, because there can be two types of stroke, kinda. And where the scar was opened to clear the bleeding, then these people are very, very critical. And then making sure medication, because once your brain is opened, you are likely to get a seizure. So managing you from this particular point, the neurologists, they need to be up to the game to make sure that you don't suffer complications.
Okay.
So, of course, now, before you recover, the nursing team, very, very critical. And if you are taking home in a certain status with stomas here and there, either for helping you ventilate and breathing, helping you feed, helping you catheter, then the nurses must appear somewhere in the knee. So those are just but to mention part of the team members who play the key role in this.
Okay.
Yeah.
And so what are the stages of recovery?
Stages of recovery, stages can be based on severity of the stroke. The very minor type of a stroke is what we call a TIA. TIA stands for a transient ischemic attack, which is like imekushtua na haijakugonga. Lakini, it just reminded you need to watch out.
So what would that person appear like?
You will present with typical cases of stroke. But if you do the investigations like the MRI and the CT scan and so on and so forth, you're likely not to find the impact in the brain.
Okay.
So at this particular, a TIA recovers 100% sometimes, but not sometimes. It will leave you with some small challenges here and there. So the journey and the stages of recovery are based on the severity of the brain damage that you acquired. But technically, the stages are determined by the paralysis of the muscle.
Yes.
At the early stages, the muscles begin to be very, very tight. And then the next stage, they become what we call flaccid, like the illegia. And then the third stage now, movement, what we call active movement. There are two types of movements, what we call active movement. And active movement is movement that I will instruct you to perform, and then you perform it without necessarily me having to help you.
Yes.
And a passive one is that me, I'll kunja and kunjua you. You know?
Yeah.
So the last bit of the stage is now the active movement. In stroke management, as I told you, separating the upper limb from the other things is very critical, because it determines whether your recovery journey. So the upper limb always is very problematic. We say the human hand occupies the biggest percentage of your brain.
Yes.
So because of the fine motor functions of the hand always lags a little bit behind.
Yes.
So you're likely to remain, you have walked, you can do other things, but the hand still remains a little bit of a troublesome. Remember, the very last stage of stroke recovery is what we call the social stage, whereby I now discuss with you, I'm taking you back to where you used to be despite the current challenge, and we agree.
Yes.
I make some very daring movements sometimes. I may want to renegotiate your job back again to your employer.
Yes.
And of course, at this particular time, I must have done a very good background of you. I'm sure you can do what you used to do. Or I go renegotiate for you for a job redescription. All right?
Yes.
Or on a very worst case scenario, I organize for an exit plan for you that will help you manage yourself in the near future. So at that social stage, it's now about making sure that you can, do what you used to do again, despite the current status.
Okay.
Yeah.
That last one sounds sad, but it's okay.
I know.
Okay. Let's sample a few questions that have come through. Harrison, hi Harrison, thank you for writing in, is asking, hi, kindly ask Dr. Chengo to talk about enhancing memory loss of stroke patients.
Oh, enhancing memory loss.
Yes.
That's a very good question. One of the best ways in my practice I've come to realize of enhancing memory loss is through kigosho. That's like the way I like calling it.
Yes.
You know those things you used to do when you were a child? Head, shoulder, knees, and toes?
Yes.
Going back there. Going back. You know the very primary language that you spoke?
Yes.
Either you spoke your mother tongue, going back there. Now, in rehabilitation, we have what we call a framework of rehabilitation, and it's called MOHO. MOHO stands for the Model of Human Occupation. And at the stage of MOHO frame of rehabilitation, it talks about intuition. Intuition looks at you at heart. What kind of a person indeed are you? What are your values? Do you value the kigosho for the church ama for the other side? Kama ni ile rumba, then it means I will take you back to that rumba person, that one. Yeah. So that means I may be very daring, and one of these fine days on a Saturday evening, nikupitishe hapo mahali you skiza that one, and then we go do it at home. So songs of childhood and practices of songs and behaviors before stroke takes through experience. This is through experience now.
Yeah.
They are very, very critical.
Okay.
Simple things like reading a newspaper every day. That is, if that is the kind of a person you are.
Yes.
If you used to read a Bible every day, then I'll take you back there. You know? Crossword puzzles.
Yes.
They do an amazing job. An amazing job. You know, you take from the simplest. There are crossword puzzles for words and crosswords for images. Yeah, those are some of the things that you can do with the cognitive rehabilitation. Things like painting.
Yes.
You know, engaging in playing music instruments. Yesterday I was reading a research that has been done by a Japanese neurologist, and he's given evidence there's no music instrument player who gets seizures. I found that very interesting.
Yeah.
You know, so music is very therapeutic.
Yes.
And it can enhance cognitive memory big time.
Okay.
Just to mention but a few. Yeah.
Interesting. You're talking about music earlier today on radio. We're also talking about the power of music, that music heals and, you know, and can do great things for someone. Please rush to at Hope FM Live. Check that content there.
I will, thank you.
Let's ask Bernard. Bernard from Kisumu, thank you for writing in and says, yes, children can suffer from stroke, especially children with sickle cell anemia. When they encounter crisis, they may end up getting stroke, and saying, good show. Thank you so much. Odong, is asking, what factors can affect the outcome of stroke rehabilitation?
Wow. That's a loaded question. Through experience?
Yes.
Family dynamics.
Family
dynamics.
Okay, let's talk about that a bit.
Comes big time.
It's really heavy.
This is very heavy. So every family is special in its own way.
Yeah.
But you come to realize a scenario where the leader of the family, who has always been a small god, kinda. And then he becomes the victim at this point. And then, you know, there are parents who have stayed in that position for so long, and they refuse to bow down and let other people take stage.
Yes.
So at this particular point, when he's affected, and he doesn't want other people to be told that I'm unwell.
Yeah.
I've been there. And that's one of the most difficult family dynamics I've ever found within my many years of practice. The other thing on family is, do you have that very close relationship with your wife, with your children, with your spouse? Is it there? Can you be vulnerable? Such that I am your son, and I tell Daddy I'll be here, I'll change you, don't worry.
Yeah.
And you really believe my son is here.
Yes.
You know, and you are fine. And I call you, I tell you, Daddy, if you have a problem, just holler, and I'll show up.
Yes.
You know, and I owe you one of those, like, I've, sorry to say this, last week I had this, where the son has not stepped in that home for 10 years. And this is the time that he's coming at this particular time of crisis. What? There will be a challenge there, you know? So family dynamics, again, you have family finance, where perhaps the sick person is the only signatory to the account.
Oh my.
You know?
Yeah.
Just to mention but a few, you know, that family relationship, I know you know
yes,
how families can be.
Yeah.
The second thing is finances.
Yes.
Money. So when this happens, rehabilitation is not cheap. All the professionals that we just spoke about. And please note, many times stroke patients, they come from ICU. So stroke is a crisis. When stroke hits you, the first place to land is in ICU. So of course, ICU is not cheap.
Yeah.
So resources have been depleted.
Yes.
And then here you are, whether the resources are there. Again, family dynamics come in money. Who has, who doesn't have, who pays, who gives everything, who has it and is stingy, you know? And all those things from there.
Okay.
And then friends as well,
yes.
circles, you know, and having those people who will come and take you out despite fanya nyama choma, you know?
Yes.
And grab you and take you for a fellowship, you know? Yeah, those are just some few factors that help in stroke recovery.
Okay.
Yeah.
A quick one before we wrap it up. This one, Jacob Kihara is asking, can stroke be hereditary?
It's a yes and a no.
Okay.
Causes of stroke can be hereditary. For example, hypertension. Hypertension, you know, it runs through a family. Sugar issues, diabetes, it runs where you find, because there's a certain gene.
Yes.
And it runs through the family. So stroke itself, per se, may not necessarily be hereditary. Excuse me.
Okay.
But you can find the causes of the stroke. They are hereditary and they run in a family.
So the diabetes,
the hypertension, just to mention but a few.
Okay.
Yeah, sickle cell.
Yes.
Yeah.
Okay.
All those, yeah.
Sawa, Ruth is asking, I had a stroke when I was a child at around class 5. and I got paralyzed on the right side. When the hospital went to the hospital, got treated, but I can't laugh correctly. I just smile without showing teeth because I don't look okay. It's not straight. How can Daktari help me?
Wow, 5 years. How I'm guess now he must be an adult, of course,
Yeah.
above 20.
Yeah.
So I'm not sure whether the lack of laughing is because she minds avoided or is the oral facial musculature. Emotional challenges in stroke can be there where you lack ability to show affect. You know, when you are laughing, you lack that ability to show the laughing face, or it looks like crying face.
Yes.
But I think what she's trying to say is she's concerned about her cosmetic abilities. There's still, with the modern technology, so much that you can still do about your facial. You know, you must feel good, eh?
Yeah.
Yeah. So there's quite a number of things that can be done.
Yes.
I would ask her to go to a plastic surgeon and express the concerns to him or her, and she could easily get some fuse, because it's easy to tighten muscles or to loosen muscles.
Okay.
Yeah, sometimes you may just inject something and then part of it loosens. Yeah, sometimes you may want to strengthen a certain group of muscle. Yeah, and then it happens.
Okay.
Yeah.
So a plastic surgeon
But I would
would
ask
do
her
her
not
well.
to give up.
Okay.
Yeah.
Yeah. So where can somebody watching us get occupational therapy services in Kenya? Because you're being watched across.
Okay.
Yeah.
All level 7 referral hospitals must have like a small department. As I've told you, rehabilitation is one of those things that have been forgotten in our health systems. It was never given priority. Because I don't understand how, as a nation, you can only create one neuro rehabilitation facility in a whole nation. It doesn't make sense. However, in every level 7 hospital facility, you can easily get help. Either from, there must be either a physiotherapy department or an occupational therapy department.
Okay.
Level 6 hospital facilities, they have, and then majority of the private institutions, they have. Or alternatively, you can always, wherever you are, you ask, we have the legal council that controls practice of occupational therapy in the country. You can always ask, and you can always be referred to the nearest facility. Yeah.
Okay.
Yeah.
What are the do's and don'ts, of rehabilitation for a patient who suffered stroke?
Wow. Do's and don'ts. One do, one don't.
Yes.
And especially at the very first scene, there must things that you need to see or you may need to be aware. And sometimes I feel like I should write it on a billboard and put it out there for people to know.
Yes.
How to see and say this is a stroke.
Please address us on that camera as we wrap up.
You look at this like this and this is a stroke.
Yeah.
So one of the don'ts is take too long to take this patient to the nearest facility. So anyone who has a face which seems to be looking different, a stammer, confusion, inability to stand, you'd rather get to A&D and you are told, you panicked for nothing. We say, do it fast.
Okay.
F stands for face.
Yeah.
Activities of the limb either. You find one limb is less active than the other. Don't waste time. Stroke is an emergency. For whatever reason, if there is anywhere where you can get that kadawa called aspirin, because stroke only becomes a problem if there is insufficiency of blood in the brain. Ako tu ukipatiana, uko ukiita ambulance, uko sawa tu. Let's deal with it as we get to the nearest facility. And always get to the nearest facility. Don't want to go to the
special one.
The special one. The nearest one where you can easily get that particular first aid. Sometimes it's as simple as giving someone a aspirin, imagine. So this is very, very critical.
Okay.
Now, lifting patients who have stroke is very critical so that you don't, especially the shoulder. As you see, when you are paralyzed, you hold people like.
Yes.
So one of the dons is always grab by the core, but not by the shoulders. Even when evacuating in places of emergency, avoid it. Those are just but some few dons. Of course, the do, as I've just said it.
Two, before we wrap it up.
It must be an emergency.
It must be an emergency. Rush to the nearest hospital.
Yes.
How can we get you, Daktari?
My telephone number is 0723. No, sorry. I almost gave you my wife's number.
Well, you'll give it to us. We'll get it to you.
So I practice at the Ability Clinics. It's directly opposite Coptic Hospital on Gong Road on Mushai Drive.
Yes.
That's our center. That's where we practice from.
Okay.
And you can always Google us at abilitytherapyplace.co.ke, or we are on Facebook. You can reach us on Ability Therapy Place. You can reach us on our official numbers at 0726272223. I'll repeat again, 726272223. That's my personal line. Or 0780888708.
Thank you. And of course, when you call us at Hope TV, we'll be able to give you the number. Thank you. Thank you, Duncan Chengo, for being with us. May the Lord bless you as you continue to minister in that great way.
Amen.
We have to wrap it here. My name is Grace Mutiso. Thank you so much for watching us tonight. God willing, let's do this again next week, same time, same station. Of course, with a different doctor discussing a different topic. Remember to share this content. It's live on Facebook and YouTube with someone who will benefit from it. And of course, catch a repeat tomorrow from 11 a.m. Shalom and God bless.
Only God can turn a mess into a message.
I have a boy on a wheelchair.
Yeah.
I'm still preaching on the pulpit.
Amen. Niliona mguu ya nyuma inakuja tu